Hello everyone, welcome to my channel Tooth Theory. This is another video meant for ACJ exam, which is Assessment of Clinical Judgment conducted by ENDODONTICS. In this video, we are going to discuss how to answer various questions pertaining to the diagnosis part. Now in this slide, what you can see is a template which is asking for the diagnosis for the tooth. It says which of the following are the most likely diagnosis for the tooth. The tooth number will be specified in the question according to the case history. Now it has listed almost all the options which are generally asked in the diagnosis question, which pertains to the pulp, whether it is normal, whether you have reversible pulpitis or irreversible pulpitis. Irreversible pulpitis, whether it is asymptomatic or symptomatic, and pulpal necrosis. These all options from A to E pertains to the pulpal conditions. So what happens is you read a case history, you take care of the pulpal condition which is specified in that case history, and when you come back to answer this question and they have asked about the pulpal condition for that tooth, you will go back to the case history and you will find out. So we are going to discuss all these conditions of the pulp one by one, so that when we go back to the case history, we should know what we have to answer. Similarly, the periodontal conditions. What do we have? Normal periodontium, symptomatic apical periodontitis, whether there is any inflammation of the periodontium or not, whether there is any abscess, whether it is acute or chronic, is there any kind of root fracture, is there any resorption. So all this information we will look for in the case history and we'll answer it here. So we are going to discuss all these options one by one so that it will be easier for you to answer the question according to the information provided in the template. So let's begin. So first of all, let us view the information about a tooth which is given in the case history, and we will answer according to the information. So whenever you are asked about a tooth, there are generally three things involved, and take care of those three things. There can be a pulpal involvement, periodontal involvement, and an abscess. So we will discuss pulp first. So when we are discussing pulp, we'll see what is a normal pulp, what is irreversible pulpitis, what is reversible pulpitis. What is a normal pulp? First of all, what is pulp? Pulp is basically a soft tissue which consists of living blood vessels, connective tissue, and nerves. That is, this is the vital portion of the tooth. Now, when we say a pulp is normal pulp, it means that clinically there are no symptoms. The tooth is asymptomatic. There are no symptoms present. When a tooth is asymptomatic, that means a tooth is healthy. How can we say that means a tooth is vital? And for vitality, for checking the vitality, we do the vitality test, which are such as cold test. Now, cold test is when you do the cold test, there is a normal response. That is, there is a transient pain. Pain is for 1 to 2 seconds. It is of transient nature and of mild intensity. This is very important. In normal pulp, the pain is for a very short duration, that is for 1 to 2 seconds, and the nature is transient and it is very mild intensity. When you see the radiographic appearance for the set tooth, there is no radiolucency. So when you go back and check in the history, if there is given any X-ray or radiographic feature, there will be no radiolucency. So to the cold test, only mild response, which is transient in nature. Now what is important here is that you have to pay attention to a thing, that when you apply a cold test, the response is immediate. Okay. But when you do the heat test, the response is delayed. Reason being, we have read this earlier as well in our AFP classes, that the fibers which carry the cold sensation are generally located on the outer side of the nerves, and the fibers which carries the heat sensations are slightly on the inner side of the nerves. So that is the reason for this kind of response. And when you do the heat test, the intensity of pain increases as the temperature increases. But in response of the cold, even if you maintain the cold stimulus, the intensity will decrease. So you have to take care of this condition. The main important thing, again and again I'm specifying, is here that the intensity will be mild when the cold test is done. Pain is for a very short duration and it is of the transient nature. Hang on. Now, what is reversible pulpitis? As the name indicates, pulpitis means there is an inflammation of the pulp, and reversible means such an inflammation which can be reversed back to the normal state. That means there is some stimulus present, and when you remove that stimulus, the inflammation will subside. Okay, so let's read it what it says. It means inflammation is present but it is reversible. So removing the stimulus will help in subsiding inflammation, so it is called reversible. Now, what are the reasons for this reversible pulpitis? In CP and caries, defective restoration can be one of the reasons. Enamel fracture, which leads to exposure of underlying dentin, can also be a reason for reversible pulpitis. Now, when you do the vitality test, when we do the cold test, the symptoms found are pain is present, which is sharp and transient. Remember this thing, in normal pulp, the pain is of mild intensity, but in reversible pulpitis, the pain is sharp. So, vitality test is positive, cold test is positive, pain is sharp, transient and short duration. And important thing to note is that when you remove the stimulus, the pain dissipates. When you remove the stimulus, there is no pain. Radiographic appearance for this kind of tooth will be normal. Now, what will be the differential diagnosis? Differential diagnosis will be dentinal hypersensitivity, which happens when the dentin is exposed. The response of the tooth will be same, sharp, transient, reversible pain when stimulus is applied. Now, important is when you are answering such questions and you are confused, generally in the case history, they have mentioned this thing that dentin is exposed. Okay, so from there you can have an idea that it can be a case of dentinal hypersensitivity as well. Now, what is the treatment for this reversible pulpitis? Since we have read about this thing that removing the stimulus will help in reversing the condition, so what we do is we'll remove the etiology, we will remove the irritants. If there is a defective restoration, we will correct it. If there is enamel fracture, we will correct it. So this is all the information we need to know about reversible pulpitis. Moving on to irreversible pulpitis. As the name states, any pulpal inflammation which has gone on to such an extent that even if you remove the stimulus, the inflammation does not subside, it stays there. So that is called irreversible pulpitis. Now, the pain present in irreversible pulpitis will be spontaneous. It occurs on its own. You don't have necessarily to apply a stimulus to have that pain. It is spontaneous and it is prolonged. It is not for 1 to 2 seconds. It can be from few minutes to few hours and the pain is very severe. So remember this thing, in normal pulp, mild intensity, short duration. In reversible pulpitis, sharp pain, short duration. Here also severe pain but prolonged, can be spontaneous. Now, pain here can be sharp, dull, localized or diffused. It varies. When you do the vitality test, the hot and the cold test, it is positive. The pain is lingering from few minutes to few hours. Now, irreversible pulpitis is of two types. symptomatic irreversible pulpitis and asymptomatic irreversible pulpitis. We will discuss these one by one. Now, in case of symptomatic irreversible pulpitis, so the name indicates there will be some symptoms. The symptoms will be acute pain, spontaneous pain. Pain will be acute, pain will be spontaneous, pain will be sharp, pain will be lingering pain. Even if you remove the stimuli, pain does not subside. These are the symptoms. Now, when you do the cold test for the symptomatic irreversible pulpitis, it will be positive. When you do the percussion test, tooth may be tender, may not be tender. Because on percussion, generally you see the periodontal conditions. When you take the radiographs, when you see the radiograph, when you look at the information provided for the radiograph, there will be no changes or minimal changes. Because when you encounter the late stage of symptomatic irreversible pulpitis, you might see thickening of periodontal ligament. There is no radiolucency as such, but you might encounter thickening of periodontal ligament. And when when a tooth reaches late stage of symptomatic irreversible pulpitis, cold may alleviate pain. The pain may decrease on application of cold. Remember this thing. It is very important to answer the late stage of symptomatic irreversible pulpitis. When you apply cold sensations, the pain might subside. Now, what is the treatment for this thing? Either root canal treatment or extraction. One thing more which I forgot to mention about symptomatic irreversible pulpitis, the reason for this condition can be deep restorations, deep caries, any kind of trauma or fracture to the tooth, or any other kind of the pulp exposure. This can lead to symptomatic irreversible pulpitis. Even irreversible pulpitis, symptomatic is when you have symptoms. Now we will go back, we will study about the asymptomatic irreversible pulpitis. Now it is asymptomatic, which means that clinically it will show us no symptoms. Either there will be no pain or there will be a mild chronic pain. And when you see the radiograph for the tooth, there may be radiolucency which is present, or the tooth may have a deep restoration, or internal resorption, might show internal resorption, because internal resorption is also one of the form of asymptomatic irreversible pulpitis. Again, its treatment will be, how will you correct it? Either root canal treatment or alternative treatment is extraction. Now, asymptomatic irreversible pulpitis is further of two types. Like you can see two conditions in asymptomatic irreversible pulpitis, which might be asked you, given you in the questions, and you have to answer that with what kind of pulpitis is it. So remember this thing. If you encounter hyperplastic pulpitis or a pulp polyp, or you see a picture of pulp polyp or internal resorption, these are a form of asymptomatic. It is not a type, it's a form of asymptomatic irreversible pulpitis. Now we'll study a little bit about hyperplastic pulpitis, which is also called pulp polyp. It is a form of asymptomatic irreversible pulpitis. It is because of chronically inflamed young pulp. Asymptomatic means there is no pain. Now, what is the appearance? It is a reddish cauliflower-like outgrowth, which can be seen coming out from the occlusal surface of the tooth, like you can see in this picture. Okay, so this is asymptomatic irreversible pulpitis. If you see such a picture given, you have to answer this is pulp polyp, hyperplastic pulpitis, or a form of asymptomatic irreversible pulpitis. Now next is internal resorption. This is also asymptomatic, so there are no signs or symptoms, only mild response to vitality test, and these are usually found during the routine radiographic examination. Let's say patient came to you just for a routine checkup, and you had a radiograph of the patient. You took a radiograph, and you will see this condition. Just look at the radiograph. Look at the picture shown of the radiograph. That this widening, this resorption, this is called Okay, so you will see an irregular radiolucency which can be present anywhere along this root canal space. So this is internal resorption and the treatment will be RCT or extraction. On to necrotic pulp. What is necrotic pulp? It means when the pulp is non-vital. It will respond negative to the vitality test. This occurs after the irreversible pulpitis. Once the condition has progressed to irreversible pulpitis and we did not do any treatment, and the infection will further spread and it will lead to necrosis of the pulp. Now, what can be the reasons for this? The reasons can be, again, carious lesion, deep caries, deep restorations, endoperio lesions, and fractures. The symptoms, what will be the symptoms? Symptoms will be mentioned. Example, you will see in the case history, it is given, there was pain initially, but now there is no pain, which indicates pathology has advanced from irreversible stage to necrosis. When you do TOP, that is percussion test, it will be tender. When will it be tender? If the inflammation from the pulp has extended to the periodontal ligament. EPT will be negative, cold test will be negative. That means vitality tests are negative, which we have discussed. So what happens is sometimes when you apply heat for a longer duration, tooth may respond to heat. And that can be further, like there is a partial necrosis, there is a full necrosis. So we don't need to go into that much details. The only thing is that sometimes there is partial necrosis and tooth may respond to the heat test. But you have to take consideration when the cold test is negative, it is generally necrotic pulp. So when you see the radiograph, there you might see there is periapical radiolucency present or thickening of the periodontal space. What is the treatment? Treatment for the necrotic pulp is either RCT or alternative treatment is extraction. So this ends our discussion with the pulp. We'll just have an overlook again about this condition. If the pulp, only the sign and symptoms, okay? If the pulp is normal, what will you see? The vitality test response is normal, okay, clinically symptom free, no radiographic signs of pathosis. When you do the cold test, the symptoms are mild and there is a transient pain which resolves within seconds. If you have reversible pulpitis, you will feel sharp transient pain when you apply stimulus, and when you remove these stimulus, there will be an immediate relief. So when you read about irreversible pulpitis, it is of two types, symptomatic and asymptomatic. Symptomatic has intermittent or spontaneous pain, prolonged and severe. Pain can be sharp, dull, localized, diffused, last from minutes to hours. And in the late stages of symptomatic irreversible pulpitis, cold may alleviate the pain. Asymptomatic, there are no clinical symptoms of pain or sensitivity. Radiograph, you might see signs of internal resorption or radiolucency. Two forms, pulp polyp, hyperplastic pulpitis, and internal resorption are forms of asymptomatic irreversible pulpitis. Now necrotic pulp, non-vital, no signs and symptoms, EPT negative, cold test negative, radiograph, periapical radiolucency might be present or PDL space. So this ends our discussion with the necrotic pulp. The pulp portion we are done with. Okay, now next is periodontal ligament. Now we are going to discuss some conditions which we have to answer according to the information provided in the template for the periodontal condition of the tooth. Now we can have periodontal tissues, periapical tissues, which are normal. We can have symptomatic apical periodontitis, or we call it acute periapical or acute periradicular. These all are same, and it will include phoenix abscess or chronic periapical abscess with symptoms. Okay, this is very important. Symptomatic apical periodontitis is also known as acute periapical or acute periradicular periodontitis, and it will include phoenix abscess. What is a phoenix abscess? Chronic periapical abscess with symptoms. Remember, this thing is symptomatic apical periodontitis. Another is asymptomatic apical periodontitis, which is also known as chronic periapical or chronic periradicular periodontitis. Now we will be discussing few important things about normal apical tissues. When we have normal apical tissues, asymptomatic, the condition will be asymptomatic if mentioned. Let's say the percussion test is given, there will be normal response, palpation will be normal, or there will be negative response to the tender on percussion. When we do the percussion test or palpation test, the response will be normal. And when we see the radiograph, there will be intact laminar dura or uniform periodontal space. Now symptomatic is, what is symptomatic apical periodontitis? When the inflammation from the pulp extends to the periapical tissue. The reasons can be irrigance, when there is hyperocclusion present, that can be a reason. And if, let's say, the obturating materials are extruding, that can be one of the reasons. What can be the findings? Findings will be moderate to severe pain on biting or percussion. So we'll just have a look on this. When inflammation of pulp extends to the periapical tissues, now the pulp condition can vary from the periodontal condition. Now when you have symptomatic apical periodontitis, the pulp may be reversible, may be irreversible, may be necrotic. So what you have to answer about the pulp, you will go back and read in the pamphlet. Now when you do the percussion test, it will be positive. Biting test, it will be positive, pain will be present. And in cases of, and if we see the radiographs for these conditions, radiolucency may be present, may not be present. If pain with radiolucency positive, it is symptomatic. Slight pain, also asymptomatic. Okay, yeah. Okay, next moving on to asymptomatic apical periodontitis. There are no symptoms, no pain, slight pain, no palpation. When we do the percussion test, it will be negative or slight pain to percussion. The patient may say that I feel different. The patient may feel different. Like patient will not say that I have pain, or patients will say that I may feel, the patient may say that he feels different, she may feel different. When you see radiograph, periapical radiolucency is present and the pulp is necrotic. So the thing is that when you have normal apical tissues, okay, the response to the percussion test or biting test is normal or no response at all. In cases of symptomatic, there is a positive response and the pulp may be reversible, irreversible or necrotic. But when you have asymptomatic apical periodontitis, percussion test is negative or the patient may say that he feels different and the pulp is generally necrotic. Moving on to next part, which is abscess. Acute apical abscess. Now what is abscess? It is a localized or diffuse liquefaction lesion of pulpal origin which destroys the periradicular tissues. So basically it is an inflammatory response to the irritants from a necrotic pulp. So remember this thing that pulp is necrotic when you have an abscess, and because of the irritants from a necrotic pulp, there is a severe inflammatory response which leads to a localized or diffuse liquefaction of the lesion, pus formation. Now, very important thing is pulpal necrosis is present. It is rapid onset. Since it is acute, it will be rapid, spontaneous pain, moderate to severe pain. When you do the percussion test, it is positive, biting test positive. Now, when you do the vitality test, EPT or thermal test, these will be negative as the pulp is necrosed. There will be pus formation, and when you do the palpation, it will be tender. There might be systemic involvement, that is, patient may have fever, malaise, lymphadenopathy. Swelling might be present intraorally. The only case when swelling is not present when the lesion is located in the bone, then you will not see swelling, otherwise swelling will be present intraorally. So the pulp is necrotic, does not respond to vitality test, EPT negative, cold test negative, test negative. Radiographic feature, you will not see radiolucency. Why? Because this is acute. Acute, it was rapid, so we will not see radiographic changes because it is rapid onset. But there will be tenderness to percussion, pain on biting, yes, present, and the vitality test will be normal. Remember these things. There might be systemic involvement present. Swelling might be present. Now treatment will be, if there is swelling, then incision and drainage, and once it subsides, RCT or extraction. If there is no swelling, you can go for RCT or extraction. If systemic symptoms are present, like fever, lymphadenopathy, you have to prescribe an antibiotic like amoxicillin or penicillin V. Moving on to chronic periapical abscess, or also known as suppurative periodical or periodontitis. Suppurative means abscess, like we have some liquefaction. Now it is chronic and it is an abscess. So what will be the pulpal condition? It will be necrosis. So the pulp will be necrosis. Now this is chronic, so it will not have a rapid onset. It will have a gradual onset. And clinically it is asymptomatic generally. There will be no pain at all or very little pain. Pus formation present. Now very important feature of chronic abscess is sinus tract present. Fistula present. This is very important. Whenever you see there is a sinus tract present or fistula present, you go for chronic abscess. So on biting, there is no sensitivity, no tenderness to percussion, but there can be a slight discomfort. Our patient may say it feels different. Since the pulp is necrosed or there is pulpal necrosis, so there will be no response to the vitality test. So EPT and cold test will be negative. And when you see radiograph, periapical radiolucency is present because the lesion has progressed quite a lot. So there will be radiolucency. Now what will be the treatment? RCT or the alternative treatment is extraction. How to differentiate it from chronic apical periodontitis? Because the same things that, okay, there is no EPT or cold test or chronic, so tenderness or percussion might be, might not be, or patient may feel different. So it is that it has a draining sinus while chronic apical periodontitis does not. Okay, chronic apical periodontitis does not have a draining sinus and chronic periapical abscess has a draining sinus. Okay, so this is all we need to know about the chronic periapical abscess. Again and again I'm mentioning this thing, specifying that presence of sinus tract or fistula is chronic periapical abscess. Now moving on. Now we have some things which are called previously treated or pulpless tooth. Whenever you have such an option, you have to take care that if the tooth has been endodontically treated and the canals are obturated with filling materials other than intracanal medicaments, then you go for previously treated. It means endo treatment was done and the obturation is completed, like with gutta percha or so. Like there should not be intracanal medicaments which we leave in the canal so that we will do the final obturation later. No, the final obturation has to be done. That is, the root canal treatment has to be completed. If such a thing is mentioned, then you go for option previously treated or pulpless tooth. Now dentinal hypersensitivity. So dentinal hypersensitivity, we know that when the cold test is done on tooth or enamel, there is a normal response, that is transient mild pain for 1 to 2 seconds. But when it is done on an exposed root or surface of dentin, there is a sharp pain which lasts for 1 to 2 seconds after the stimulus is removed. So in that condition, we come to know that pulp has nothing to do with this. This is dentinal hypersensitivity. This is a hypersensitivity response because of the exposed dentinal tubules. Now, what is the treatment? Desensitization. Now, there is another condition, vertical root fracture. Whenever you encounter vertical root fracture, the complaints from the patients will be variable. First of all, pain. Pain will be mild to moderate. And the complaints from the patient will be there is a discomfort in chewing or pain on biting. Okay, the patient might say in the history it might be given that patient has a discomfort in chewing or when he bites there is a pain. Pain can be mild to moderate. And when the diagnostic test, periapical radiograph and bite wing radiograph are taken and the clinical findings are, we will tell you that what the X-ray shows, but before that clinical findings will be deep narrow probing pattern at the site of fracture. This is very important. There will be only a single pocket present at the site of fracture, which is also called as blown out pocket. Let's say that we are doing the 3 sites at the fracture site, the pocket will be very deep, let's say 8 or 9, but the other other readings will be normal. And the most common cause is previously endodontically treated tooth because it becomes weak or post-placed tooth. There is either a history of post-placement or previously endodontic treated tooth, or you might be given a perio chart in which you will be given a reading that at one side the pocket is very deep while at the adjacent sides the pocket is normal. And so the X-ray shows us J-shaped radiolucency or angular bone loss. This is very important for diagnosing a vertical root fracture. So what are the conditions? We'll go over it again. Pain will be mild to moderate. Patient will complain of discomfort in chewing or pain on biting. Diagnostic test will show, the X-rays will show you J-shaped radiolucency or angular bone loss. And clinical findings will be deep narrow probing pattern at the site of fracture or a blown out pocket. And the common cause which might be mentioned in the case history is that there is previous history of endodontic treatment or post placement in the tooth. This is all we need to know about vertical root fracture, and this is all we need to know to answer this.